Okay, Shelley, would you like to do the roll call, please?
Ma'am. Mary Baker Shaw.
Ani?
Mike Robbins.
Here.
Mr. Austin.
Here.
Earl Davis. Joe Bird.
Honey.
Julia Coates.
Here.
Sean Crittenden.
Honey.
Jody Luke. Shannon Duncan.
Honey.
Rex Jordan.
Here.
Darryl Legg.
Here.
Wes Snowfire. Gloria Petskowski.
Here.
Mike Shambo. Theo Smith.
Here.
Denise Taylor.
Here.
Victoria Vasquez. We have a quorum.
Thank you, Shelley. Approval of the minutes. So move. Anybody second?
Second.
We have a motion to approve and a second. All those in favor say aye.
Aye.
Okay, our first report is George. Is George on the line today? He's not, is he? Okay,
Have we requested George to zoom in to, have we made those, okay.
Every month we send him a link every time we have meetings. Last time he was in quarantine.
oh, last time he was in quarantine, yes. Well, let's send out another invitation to see if he can zoom in with us at the next meeting. Okay? Anybody have any comments about his report? Or questions? I guess we could email them to him. In which case, then let's go to Cherokee Nation Health Services, Dr. Steve Jones. Dr. Jones, are you on the line?
Yes, ma'am. Sure
Hi.
I am.
Hi,
Can you hear
Steve.
me okay?
Yes, we can hear you just fine. Would you like to give us your report, please?
Sure. So the written report is in your packet, and I'll just kind of go over a couple of quick things with it before I get on to some of the things I want to update you on. Of course, I want you to keep in mind that these numbers that you'll see in the report are always collected in August, so they're from this actual September report is from the July numbers. So when you look at that, and I know we made kind of remarks about how many babies we had delivered in August, and this report actually reflects July, which was 72. So there's a little bit of a lag in information on data collection on these reports because of the time where the timetables fall. So, all right, we'll move on into under some of the things that you guys are in tune to each month is contract health or purchase referred care, and you can see on page 3 there that we spent $45.1 million as of end of July. The referral approval rate is 97.4%, and then it's broken out by location there in the graph below that. We move over into the next page where you'll see we had quite a fall off in some of those ambulatory case visits or monthly visits. Of course, that was during the time when we were starting to ramp back up on our telehealth and bringing some of our services back online. So you'll see those numbers start to improve each month subsequently from this. So, and as a result, our revenue is off since we had reduction in the number of visits. All right. Some of the things I want to talk about and pull your attention to. On the first page of that report, there was a comment about the interventional radiologist. So that's a new service line. We've got an interventional radiologist starting with us.
Dr.
and we're
Jones,
starting
Dr.
to,
Jones.
Key that up.
Can you please speak just a little louder, Dr. Jones?
Talk a little louder.
A little louder, yes, sir.
Okay. I don't know how good my microphone picks up to you guys. So interventional radiologist is starting to pick up. That will help us reduce our cost on contract health or purchase referred care. They're able to do a few of the things that we normally send out to do. So that's a new service line for us that started should be coming online this month. Radiology services, we are backlogged on a lot of, as you can imagine, a lot of things like MRIs. So Counselor Buzzard had made reference to it a couple of weeks ago when we met, that we are seeing patients on the weekends from 7 to 7. Our team is working to get a lot of those MRI backlogs done, and as well as our plans in the next week or two is to start mammography on the weekends. So in addition addition to our regular schedules through the week, we're going to have those available on the weekends here at CNOC. We've got several construction projects going, as you know. Stillwell project's on track. The OSU project, I'm told, is on track. We have a remodel project going on at WW Hastings in the area where primary care was located previously. We are remodeling that area for our medication-assisted treatment area, which will move out. Our MAT treatment is what you probably heard referred to as. We'll be moving that out of behavioral health area over into the Hastings remodeled area to allow us better access and also improve access and availability up in the behavioral health area. We're anticipating that renovation will be done in November, and we should have those services online in December. We started with a model at Three Rivers where we moved the pharmacy refill center out. That is complete, and we are up and functioning at full capacity here in the TEC building where we moved that center. And so we're starting to remodel the area where we vacated at Three Rivers to make it primary care. We'll be bringing, when we get that completed, that'll make room for 2 more positions and 2 more mid-levels for that area. We've also started a remodel in Bonita, in the medical records area, where because of technology, some of that area was not needed. We've identified an area we can expand our primary care there, and so we've started working through that process. Surgical services, we are, as of last week, up to 25% on the elective surgeries. Now, all of our normal emergency surgeries and things of that nature are continuing and have always continued as needed, but we did put a delay on surgical elective surgeries. But we have opened that back up to 25% capacity, and each week we have a team that meets, looks at bed capacity, looks at staffing capacity and things of that nature, and then they give us a recommendation on Friday, and we make that recommendation for the following 2 weeks from that. So we're staying ahead of that and just watching all the parameters of ensuring that we don't overrun our med surge and ICU bed capacity in case we have a surge with the COVID, of course. We have a flu clinic starting up. We have received some of our vaccine. We have already started vaccinating our employees, and we have a schedule built for our flu clinic teams. We've identified 4 teams that will be working through this next few months to reach out as many people as we possibly can. We've built a schedule, and we're going to be communicating that with Ms. Montgomery to communicate with you guys so that hopefully we can work together to let people know where we're at when we're there. Because of staffing and because of our capabilities this year, we're not going to be able to be accessible to just have short notice set up a flu clinic. Instead, we've built out a full schedule of 250 plus locations that we're going to be hitting at certain times, and we would like your cooperation in helping us to get the word out when we come to your respective districts so that we can vaccinate as many people as possible. Some of those events will be both vaccination and testing events, and some of them will be flu clinic only. So I just want to make sure, and we'll get that scheduled out to you as quick as possible. I just went over and approved it this morning, so it should be hitting you this afternoon or tomorrow as soon as Terry Lee gets it out to you. We have the latest numbers in this morning on the COVID numbers. I know this is of interest to you guys. Cumulative cases within Cherokee Nation, 1,716. We're currently following or monitoring 330 active cases, and that number has continued to increase over the last week to 2 weeks. So we're starting to see a little bit of a uptick on our number of cases that we're actively monitoring. It seems to be the largest percentage of those currently is in the 18 to 35 range, but we have seen an increase in the school age range also. So 31.8% is about 32% in the 18 to 35 range, and 17 and under about 14.5%. So we've seen that ticking up a little bit. We've been working with, this is a good note, we've been working with Gilead. So one of the medications that has shown promise or shown to reduce the time it takes to recover is called remdesivir. You've heard about that on the news, I'm sure, and currently it requires a 5-day stay in the hospital to receive that. It's a 3-day in a row dosage transfusion. So Gilead has a study or that we've been working to get in on or be a participant of for an outpatient use of remdesivir. We've had our first site visit and we were approved through that. We haven't got our final approval yet, but they're looking at our processes, and it'll be a blind study. So some patients, it's a voluntary study that patients can sign up for if they choose to have it remdesivir at home, and some patients will get the actual drug, and some patients will get the placebo, and that will be explained if someone decides they want to voluntarily sign up for it. But we're looking to get in on that study and hopefully help to get that approved for home use, similar to the type of medications like you would hear Tamiflu for the flu that helps to reduce the amount of time it takes to recover. So that's interesting, that's exciting news for us, and our team and the infectious disease team is working hard to get us approval on that. More information to come on that as we move forward. So we'll know in the next couple of weeks if we get approved for that. All right, that's all I have. I have to update you on currently, so I will take questions if your wishes, Madam Chair.
Thank you so much for that report, Dr. Jones. We appreciate it. Speaker Byrd.
Dr. Jones, when the new vaccination comes out, do we work through the State Department, or is the federal government going to allow us to administer this vaccine? That's one. And are we able to store it with the requirements that it has with certain temperatures like we do the flu shot?
So we don't know exactly what the requirements are going to be yet. There's been some initial talk that the 2 leading vaccines currently out have 2 different, one of them is a 2-shot regimen, and the other one has some specific requirements on storage. We don't know what those are yet. We're anticipating that we will be able to meet those needs. Our understanding currently is those are going to be coming through the federal government through the Indian Health Service, which we've been working very closely with for all of the testing capabilities and a lot of the PPE that we've been receiving. So we don't know exactly how that's going to come yet, but that's the way that we're anticipating it will come to us. We are part of what we call a push partner project, which is a very, and we have ran some exercises for that to vaccinate as many people as possible. As a matter of fact, last week we ran push partner drills using the flu vaccine on our own employees. So we had a push partner drill at each clinic, and we're able to get as many employees vaccinated as quickly as possible. In some cases, like Ochaleta, we had all the employees vaccinated within about an hour. So we're running those drills to see and make sure we have all the bugs worked out. So when that does become available to us, we'll be able to vaccinate as many people as possible, as quickly as possible.
That's good news. Thank you, Dr. Jones. Thank you, Madam Chair.
Thank you. Yes, Chief of Staff Inlow.
If I might, and Speaker Byrd actually asked a question along the line of what I wanted to emphasize and highlight. As Dr. Jones spoke to that, a couple of things I really wanted to point out to the council and add a little oomph to his message. And first one is Gilead. That is a huge deal for us to be pushing that out. And although we've been using remdesivir as a treatment inpatient, for us to be able to offer this as potentially an outpatient and have that partnership is a big deal. Secondly, the flu vaccine clinics. We do want to work with the council, just like we've done with the different food initiatives, and try to connect with as many people that are out there, working with our community organizations. And the very reason we're doing this is not only to get the flu vaccine out quickly and efficiently, but for us to learn from this as the vaccine for COVID-19 is hopefully right behind that. We work out all the kinks. We have everything in place so that when we get the vaccine for COVID-19, we've already run through it with the flu vaccine, and we're able to get it out to our citizens and communities quicker and more efficiently, and making sure that we get as many people vaccinated as fast as possible. So I wanted to put a little bit of a precursor behind that too, and let you know that's why we're doing the flu clinics the way we're doing them this year, is understanding that we've got COVID-19 that's going to be right behind that potentially, and we want to make sure we have a good game plan in place. We want to work with each of the council members to help facilitate the vaccination. Thank you.
Chief of Staff Enlow, I have a question. When that vaccine becomes available, will we be expected to buy that, or will it be given to the tribe?
It would be my understanding that it would be given to the tribes. I wouldn't expect that we'd have to buy it. And to Dr. Jones' point is, IHS has been a terrific partner for us and has worked very hard to help us get testing supplies and additional PPE as needed for the medical team, and they've been a great partner. So my assumption and my understanding would be that it would come through IHS and there would be no cost associated with it.
Thank you. Any other questions for our Chief of Staff? Councilor Deere?
How are you?
Good.
Hey, so since we talked about the clinic with everybody about the one at the Hard Rock going in, is this a good reason to go ahead and maybe push a modular building out there to get that process a lot faster?
Yeah.
I mean, because that's gonna hit a lot for
Yeah.
that district, so.
Yeah, that's the very thing we're looking at, and I've got to follow up with Mr. Garrett and the team this week to discuss that.
All right, 'cause I think, yeah, that'd be great to serve, pretty much serve every district, so.
Yeah.
All right, thank you.
And, you know, the potential for drive-throughs and things that we're looking at. So you know, obviously, we're going to learn a lot through this flu vaccination, but we want to make sure we deliver it efficiently and safely to everybody.
Thank you, Madam Chair.
Any other questions for our Chief of Staff? Okay, Councilor Shambaugh.
Dr. Jones, how are you, sir?
Good, thank you.
I have a question about drive-through testing. It says there were 3,428 tested in July. Do you have a breakdown of that, of each testing center? Are we seeing that some counties are higher than others or some lower? Or are you able to look at that and see where more of our cases are coming from?
Well, there is a dashboard on our website that will show you the number of cases per 100,000 by county. So that, you know, is ever changing, obviously. As far as the drive-throughs go, I do have a break. I can get it broke down. We just kind of get total numbers. I don't get that granular into it, since it is something that, you know, we're depending on people to come to us. And so there can be a little bit of a skew in it from the standpoint of, you may go, if you work in another area, you may go there to get tested on your lunch hour or right before lunch rather than where you actually live. So it's not going to be as useful to residents as maybe just the positive test ratio that you'll find on that dashboard. And again, it's broken down to per 100,000 population.
So it isn't broke down monthly.
I can get it broke down monthly. I don't have that at my fingertips, but I can get that broke down and get to you. So far, total testing, we've done about 19,000. Let's see. Let me look back over here. Around 19,500 tests total. But I'll have to get it broke down more granular if we want to have it by month or by facility location.
So do you,
Is that something that you would like for me to get broke down for you?
Well, I think it would be interesting to look at that and see what counties are higher than the other and who are testing more. I mean, Tahlequah, obviously, I would think would have more testing done at Tahlequah than Jay. I would think, that may not be the case, but is this 3,428, is that pretty close to what it's running a month, or is that up, or is it down, or what?
Yeah, that's back in July.
Right.
And numbers have actually gone up in August. Testing numbers have gone up because we've opened it up to, doing asymptomatics. At one point, we were doing symptomatic only, and then we opened it up in August to asymptomatic and symptomatic patients. So before, unless you had symptoms or unless you had someone from the contact tracing team say they want you to be tested, then there wasn't a need to test until in the month of July. So those numbers have come up since then.
And I'm sorry, I might have missed it. And how many tested positive out of those 3,428 in July?
In July, I don't have it broke down by July. Total number we have is 1,716 cases total for the whole Cherokee Nation since the start of this, or for our health system. Currently, we're following 330 active cases currently. So we have 330 people that are being monitored every day, and then as they get their symptoms go away and we consider them recovered, then they fall off that list and we pick up the new test positives.
Well, I would think it would be, if it's not too much trouble, if you could look at that and what it's doing per month and if it's going up, I mean, I think it would be interesting to see what our counties are, how they're being affected each month, and if it's going up or staying the same. I think that would be pertinent.
Yeah, it ebbs and flows. I mean, you have counties, like I said, if you look at that dashboard, you'll have counties from one week to the next that the state puts out a dashboard once a week. We update ours a little more frequently than that, but it ebbs and flows. So you'll have counties that become red, and then they'll fall back to orange, and then they may teeter back and forth between red and orange on the criteria of whether or not it's a hotspot or not. Adair County was a hotspot early on. They've since then fallen back to an orange on the dashboard, but Cherokee County and Sequoia County were both in the red for most recently. So it just ebbs and flows from week to week and sometimes from day to day on those cases. But across the board, we have been seeing an increase in schools have opened across the board to our counties or our jurisdiction or our reservations. So we have not seen that fall off like some of the other states have seen. If you look at the national map, right here in Oklahoma, we've stayed pretty hot in our area.
Okay, well, that's all I had. I just thought that if you could look at it from month by month, you could see what the difference is from 3 months ago to now, or 2 months ago, if there's any variance or difference.
We've definitely seen an increase, and I'm going to pull up a map here real quick. So that map that our test positive rate, that's something that we look at. If you want to, we can talk about that for just a few minutes. So if we go back in the test positive rate, we look at trying to stay at 10% or below. That's kind of the epidemiological threshold for whether it's community spread and getting worse or getting better. And so if we go back, we hit the 10% mark on July 4th, the week of July 4th. We actually crossed over that 10% mark, and we've stayed above that 10% mark ever since July 4th. So building up to it, we were staying below that consistently. And we have hit, as recent, last week, we hit 11% even. So we've been as high as 14% in a week. And we're the last 3 weeks, we've been at 11, 11 and a half, and 11 again. So, we're staying at that. That's about the 11% is the test positive rate for us across our system. So that being said, you can, based on the criteria that the epidemiologists say is community spread, you can say it's still, community spread, and we're not down to that area where we're making a headway on reducing it yet.
All right, thank you, sir.
Okay, Counselor Buzzard.
Yes, Dr. Jones, there's just several things here, and I know you've got most of these under control, but I noticed third-party billing is quite a bit lower than what it usually runs, and I can understand why that's being like that. The other thing is the left without being seen. I've noticed, I think in May, we were doing fairly well. Then come July, and the percentages run up a lot. That concerns me a little bit, and I don't know if you know why that's happening or not. Of course, dental is way down, and I understand the reason for that. And I think last month you reported back that we were up to 75%. So hopefully we'll see an increase of revenues coming back to there, and also for patients being seen. Just a couple more things, just to remind you. Veteran signs and the expected mother signs at Hastings Hospital. Just keep that on your radar. The other thing that I've been hearing about is anticipation of newborns probably in the month of October, November, and December. And I'm wondering if we're prepared to see all those patients that are going to be coming in with newborns. Other than that, those are just some comments.
The one without being seen, actually the graph is a little bit, you have to look over to the axis on the graph and see the number. So it does look like there's an uptick, but the uptick went from 1.6 to 2.1 patients. So, it's not a large number on the graph. It looks a little larger than just because of the short time frame and the axis of 0 to 6 as being the top number. So it looks a little bit more of an issue than it is. So during this time, with the number of patients coming in and out of the ER and urgent care, it's considerably lower than it was before we started working on this project. But yes, there was a slight uptick. The veterans and expected mother signs, so did a little investigation of that. We did have those posted at Hastings, and whenever we had to give up part of the parking lot for the Lucky Down area for the OSU Medical Center, that was where they were located, that's closest to the building. On that, I guess it would be the south side of Hastings entrance there. So that is where they got taken out, and the administrator there is working on locating a new space for those. So that's been addressed. As far as new babies coming, we had 104 was the number for August, and that was the largest number of newborns that I think Hastings has ever seen. So our staff has worked extremely hard, and they're to be commended on handling that increased load. And since we hit those marks and we're able to handle that without, I won't say without any problems. Of course, it was a lot of work for our staff, and I don't want to discredit that at all, but we were able to handle that. So that was a record number. I would say that we are prepared as much as a hospital can be prepared for those increased numbers.
That sounds great. The other thing on the veterans and the expected mothers, there wasn't any signs whatsoever at the new building there, so there's none around there. The other thing is Wi-Fi. I've been approached by several people, and I think I've brought it up before. Wi-Fi at the WW Hastings Hospital, the new clinic, and all the clinics in our outlying areas. As you know, a lot of people are doing work from home now, they go to the clinic and they sit there, you know, for some times, and they can be doing some work there. So I don't know, maybe the chief of staff has something like this that he could address this by, but I think that's sorely needed out there. You know, we're in the tech world now, and it seems to be, we're a little behind as far as tech goes in those clinics. And I realize, you know, some of the stuff has to do with the machines that are in our clinics and hospitals, but if you go to some of the other hospitals in Tulsa, you know, that doesn't seem to be a problem there. So anyway, I just want to bring that to our attention here and let the committee know and the chief of staff know about Wi-Fi. So, but thank you, and I think you're doing a good job up there, Doc, and I know this is trying time for everybody, but you know, the world has to keep it functioning, so appreciate you. Thank you.
I'd like to say that these glass partitions, and I'm thankful our staff put these up for our protection, our safety, but it muffles a lot of the sound. So if everyone could speak just a little bit louder when you address a question, it would be helpful, I think, to everyone. Yes, Councilor Buzzer, was that all your questions? I'm sorry. It was? Okay.
Harley.
I think it
Yeah,
was.
that's it.
Okay. Does anyone else have any questions? Councilor Westfire.
Doc, on the surgeries that we're not doing, on the elective surgeries, is there a way to get a list of that? I know that, for instance, you know, I had a baby that was born. I don't know if it's still going on. He was a boy back in March when it all kind of went down, so he wasn't able to have the circumcision done. Are we still doing those? And if not, can we get a list of the surgeries that we're not doing?
I don't have a list, but I can ask and see if there is something we can do. I know that what we're doing currently is just is delaying the elective surgeries. Of course, there's a list that's kept of everybody that's needing to have surgeries done that are not considered essential at this point in time. So, and I'm sure it goes back. I can't speak exactly because I haven't gotten to that granular on the process, but I'm sure it goes back to going to the top of that list and working their way back down from the person that was delayed the longest to go to the most recent. So, but I do know that the staff is working hard to try to meet the needs and still keep our hospital as accessible as we can for those needs that we feel and anticipate for the COVID patients. I will say that looking at the census this morning, that we saw a lot of patients over the weekend, and a very small percentage of those that are in the hospital currently are COVID patients. So there are a lot of other disease processes, a lot of other emergencies that we're dealing with that are outside of the COVID, and we have to take that into consideration too, to make sure we don't overwhelm our bed capacity. Should we have a surgery that requires someone to have overnight stay in the hospital? We are looking at trying to get the outpatient backlog, the ones that don't require stay in the hospital, of course, knocked out also. But again, with staffing the way it is and the requirements that we have, just all of the things that go into keeping the surgery center going and making sure if there's a complication, we have a bed to put a person into, is what that team looks at every week. Dr. Montgomery leads that team, and then he makes the recommendations from there on whether or not we increase our elective surgeries and start ramping up, or if we pull back, or if we delay them completely. So I want to listen to those experts and make sure that we have all their input and before we make those determinations. But I don't have a list of every surgery and what's been delayed and what hasn't. If it's deemed essential and needs to be done, then we are not delaying those. If a patient has to have something that's a C-section, for example, we're not shipping those out. We are keeping all those in-house and doing all that we can to keep all those needs met.
Okay. I know two that aren't getting done that are elective surgeries that would be outpatient surgeries. So I know that there are probably a lot more that goes with those outpatient surgeries that aren't currently being done, and it'd be nice if we had a general list of what to expect if we're having citizens call us and tell them that they're not getting their referrals approved because we're not doing those surgeries. So that'd be great.
Is that all,
Thank-
Councilor Noble?
thank
Okay.
you.
Anybody else have any questions? Okay, I have just a couple, Dr. Jones. At what point in time will we resume our normal patient load? Do you have any idea?
Can you repeat that? At what point in time?
Yes, do you anticipate that we'll resume a normal patient load?
It depends a lot on our staffing and as we bring people back to work. So, and you know, the other thing that we're working through that has been a challenge is that balance of telemedicine versus face-to-face. And we are getting a lot better at that. We are getting more efficient at it. That is a challenge in rural Oklahoma because of the ability for broadband services. So we are ramping up slowly. I think we're a lot further along than we anticipated we would be at this point. I can't tell you exactly when we'll be expected to be at 100% capacity. It really is a ebb and flow depending on how the virus, how many people we have out for quarantine or actually infected with the virus. Our staffing patterns really dictate a lot on what our capabilities are. So we're trying to get more efficient at being better at the telemedicine side of it because our patients are becoming more in tune and more, they expect that in a lot of cases. It's becoming more of a commonplace for people to expect the telemedicine versus the face-to-face. And so we're working on that capability every day. And I think we're getting better at it in our numbers to Councilor Buzzard's comment earlier, seeing our revenue down. I watch our revenue very closely, and the last few weeks our revenue has been coming back up. So what that tells me is that we're getting better at seeing our patients and meeting our patients' needs where they're at. So I anticipate, in the short period of time, hopefully by the end of the year, we'll be back up to 100%. But it's hard to say because it's hard to, a lot of that's dictated on the staff we have available to meet those needs. And if we have a huge surge and we have to start pulling people back for other services to keep them open, we'll have to start making, prioritizing what services are most important down to the ones that are, and I won't say least important, but less needed, and we may have to pull staff together to keep those essential lines open. So it's a week-to-week and sometimes day-to-day decision-making on how much access and the battle to keep that access open for all of our patients.
Very good. Dr. Jones, are we fully staffed yet? I mean, has everybody come back to work yet?
No, not everybody's back to work. I think the chief has in the last, has remained at phase 2. We're a little bit ahead of that because of our service lines are essential in a lot of areas, so we pull people back a little quicker. The ones that we're needing to pull back, in some cases, we're not pulling people back unless we absolutely have to have them. But there are cases out there where service lines are, especially in the smaller clinics where you only have a few people providing that service, and if you have someone out sick or someone that has a high comorbidity, then we look at whether or not that is an essential person. If they are, then we ask them to come back. So it's a balancing act right now, and we're working our way through it.
Okay, and my last question, Dr. Jones. I was surprised by the main diagnosis at WWH. It's obstructive sleep apnea. I was confused by that because usually I would have thought it was hypertension or diabetes.
So
Have we got someone doing sleep studies or something?
I'm looking, let me pull it up.
There was also a pediatric condition.
Yeah, adult pediatric, yeah.
That's weird to me.
Me too, thank you.
Never heard of that.
So what happens when we pull these? We pull them off in a time frame, and we may have had an area where we had a backlog of patients in a certain criteria, like you see a lot of hypertension on there. So a lot of people coming back in to get their meds refilled, or it was time to have a face-to-face visit before that refill could happen. Similar to this, it could have been that was a backlog that caught in that time frame. Because in July, remember, we were starting to come back to seeing patients and coming and ramping back up. So that was the start of that ramp-up process. So we're going to get some skewed numbers because people were waiting for a certain provider, or they were waiting for a med refill or something of that nature, and it required a face-to-face or a telemed visit before that could happen. So I think that's, when I looked at this list and saw all the hypertension on there, I think that was that time frame when a lot of refills were getting ready to be done and required that face-to-face with a provider before that refill could be done. So and there was a time period there where we were only seeing acute care only. So a lot of the chronic illnesses follow-ups weren't done for a very short period of time. And then, of course, as we got telemedicine online, we started seeing those all ramp up. So I think we're going to get some skews on our statistics for that period, for those first few months as we ramped up, because we were meeting those needs of those patients that had prescription needs first, and making sure that we kept everybody's medication up where it needed to be.
Dr. Jones, there are only 48 diagnoses according to this at Hastings. I think the numbers that you were given are possibly incorrect. I mean, every clinic has more diagnoses than that, every one of them except Hastings. And I was just going to point that out. I think somebody's possibly given you some erroneous numbers.
But you also got to remember that Hastings no longer has outpatient care. We moved all that over to CNOC, so a lot of their care is going to be, that you're going to see coming out of there, are going to be urgent care and ER needs and things of that nature. So I'll have them double check and look at it, but I agree there is going to be some information that's not going to be as consistent as what we see normally over the course of a year because of the way services have been disrupted.
Okay, thank you very much. Does anyone else have any further questions for Dr. Jones? Dr. Jones, excellent report. Thank you so much. We appreciate you.
You're welcome. Thank you.
Okay, next up is Thelma Pittman with PACE. Thelma, are you on? Is she online?
Yes, she's just on mute.
Can she say hi? I don't see her.
Can you hear us?
Yes.
Madam Chairman?
Yes, Thelma.
Okay, great. We are here. Ms. Davis is with me. We're both going to give you a real short report. I know time is short, but we appreciate you letting us give you our numbers today. September, you have your written report in your packet, I hope. I got it in on time, so hopefully you have it. We started September with 189 folks. Native Americans, we had 48%, Caucasians were 49%, and there was a mix of Hispanic, multicultural, and African American were the other 3%. Our employee base is 59% Cherokee citizens. We have 6% that are other Native American, and 32% of those folks of the 68 are non-native. Right now we have 15 folks in long-term care, which is one of our major expense drivers. We have 14 folks in assisted living, 3 in skilled beds, and 2 in respite care, all under the direction of our medical director and our providers. We ended July. You have July data in your report because August and September have not been booked yet. We ended July with $618,000 bottom line. It came from a loss of $125,000. So because of COVID and the other things, the telemedicine, we have been able to save some money and direct telemedicine. We have been able to give our folks activities. We've been able to provide meals. And we are working probably at 30% employees right now, but we've been able and managed to pay everyone as the Cherokee Nation has directed. We also put our semi-annual newsletter attached to your report. And I want to remind you that our fall weather is coming. The drivers of our expense is inpatient, outpatient, long-term care, pharmacy, and specialty services. And right now, Ms. Davis will fill you in on our COVID.
Well, the good news there is that we have no active COVID cases. Of all of our participants and employees, we had 5 tests positive earlier in the year, but nothing else. Our day center remains closed at the direction of the medical director. The state has given leniency and allowed medical directors in their specific areas to make decisions if to reopen or not. And right now we are not reopening because we are in a red status. We have our staff are calling our participants 2 times a week, and we're documenting that. We're providing behavioral health via phone calls and telemedicine. So we're making sure they get as much of their services as they can. The big missing thing right now is obviously coming here to eat. We deliver about 180 meals a week. Our drivers are providing those, and the tribe has been great to provide some of the food items for us as well. We purchased what they call Grand Pads, and it's a device to allow people to visit with our participants and provide care. We're hoping to purchase some more and add exercise classes and some more activities that like we had before. And that's pretty much it.
Very good. Thank you so much for that report. Does anyone here have any questions that they would like answered? I have one. Will you all be doing flu vaccinations when they are available?
We provide those to our citizens and our staff.
Very good. Very good. Anybody with any other questions? Anybody? Okay. Well, thank you, ladies, both for your all's report. We really do appreciate it, and you all have a blessed week. Okay.
Thank you, Madam Chairman.
Next up we have is Cherokee Nation Home Health and Cherokee Nation Hospice. April, are you there on the line?
I'm here. Can you hear me?
Yes, April, we can hear you fine. You want to give us a report, please?
Well, I'm sorry, what was it?
Would you like to go ahead with your report, please?
Okay. So I will get started. You should have your reports in your packet. I will just go over our census and then a quick COVID update, and then I will be happy to answer any questions that you have. So our home health census as of 9/1 was 228. Since June 1st, we have served 223 Native Americans. Our hospice census is 21, and outreach we have 743. Our total all employees is 159, with 58 of those being full-time. 90 of those are Native American and 81 are Cherokee. So a quick COVID update. As of August 31st, we have had only 10 patients test positive for COVID. As of today, we have 1 active case that we are monitoring. Our employees, we are happy to report we have had 0 employees test positive for COVID, so that's been really good. Our employees continue to get out there every day, and they've responded with a lot of courage and really taken this head on. So we've been really proud of them and what we've been able to do. I would like to send a special thank you out to Chief Boskin, Deputy Chief Warner, and this council for including Cherokee Nation Home Health Services in the hazard pay. That was very much appreciated from all of us here. So we definitely thank all of you for that. The Treasurer's Office, I know they worked extremely hard to make sure all that got out and timely, and everybody did a wonderful job. So we're extremely thankful for that. Also, a special thank you to Chief of Staff Todd Enlow and Brian Hale from the hospital. They were able to help us early on during the pandemic whenever we needed PPE. We, as a small agency, had some difficulty securing that with our vendors, and so they stepped in and did a great job and made sure we got what we needed to be able to take care of our employees and our patients, and then they also set us up with some vendors to make sure we could continue to get that PPE. So overall, we've been doing okay. So that's all I have for the report.
Great, thank you, April. Does anyone have any questions for April? April, I have one. The death that was related to COVID-19, were they in the hospital or were they home?
The patients that we have, they may have had a short hospital stay, but they were on services at some point in time during their case.
Yeah, I'm sorry about that. Yeah, I hate that. Well, April, thank you so much for joining us today. We sure appreciate it, and we appreciate your report.
Yes,
Thank you.
Thank you for having us.
Okay, is there any old business? Any new business? I would like to again thank our staff for providing us with the safety partitions between us to keep us all safe. I think they were great to get it up, and they did so expediently this morning, and I appreciate that personally. Okay, our next meeting is scheduled for Tuesday, October 13th, tentatively at 1 p.m.
Madam Chair, announcement?
Yes, announcement.
This Public Health Subcommittee is meeting September 24th, 11 o'clock. We'll hear a report after 6 months.
Very
It'll
good.
be very informative.
It should be very informative, especially with all that they've been involved with the COVID-19. Any other announcements? Take a motion to adjourn? Second?